with your spouse or something. And then a chance to just talk about, like, one of the questions at the end is, like, what would you actually buy? Like look at solutions. What's it that you actually get over that hump of just like, oh, it's cool. And actually,
Good morning, Doug.
Hello. Are you Kira?
How are you doing?
Good.
I just graduated from Ottawa University. I'm staying here for 5 years.
So you turn your budget?
Less than 2 weeks. I just got back from...
All right, everyone. Good morning and welcome to Hackers and Healers. I'm Nelda. I'm with AGI Ventures, and I'm the Chief Ecosystem Officer and here to kick off this event. Raise your hand if this is your very first hackathon. Wow, love it. Raise your hand if you are a veteran hackathoner. Okay. You know, I love this because when it comes to like hackathons and learning how to create apps using AI, whatever tool you're going to use is going to be like a gateway drug that will take you down the rabbit hole of bringing all of your ideas to life. And that's what I'm very, very excited to see happen. So, today we have a lot of exciting folks inside this room. We have physicians, we have students, we have developers, almost like everyone who's very interested in solving real problems for doctors and physicians. I remember when I first learned about this hackathon and the potential of making this hackathon happen, I was so excited because our hackathons that we held at AGI Ventures last year were all about using tools to bring ideas to life. It was about building things that are just super, super fun and testing the limits of what is possible. And this hackathon is completely different. It's solving actual problems. So before I came here in Ottawa, before I had a startup, I was a UX designer. And one of the important aspects of having great UX is understanding who your users are and who you're building your products for. And this is one of the rare opportunities that you can do that, having a diverse set of skill sets in a room to help you build. So this event would not be possible without our sponsors and our hosting team. So as I mentioned, AGI Ventures, we hold events, hackathons, hacker cottages, and we also help organizations become more AI native and build that ecosystem to support. And we also have the Bruyère Health, the Ottawa Hospital, and University of Ottawa, Department of
Family medicine.
Of what?
Family medicine.
Of Family Medicine, and Invest Ottawa. And then for our sponsors, we have Elspark. They're going to be over there. And actually, raise your hand, Elspark, so they know where to find you. So Elsa and Aaron, they're up there. And then we also have Clinician. There he is. And Tally, is Tally in the room?
I don't think so.
No? Okay. And then Telus will be Aaron and Elsa too. And then Compounded, Ugo, you'll find them later. We're going to be a really awesome room. So, your host, I am Nelda, like Zelda. And then, do you want to introduce yourself, please? Oh.
Good morning, everyone. I'm Arun Radhakrishnan. Lovely to see all of your faces this morning.
Hi everyone, I'm Zach. I'm a applied AI researcher. Thanks everyone for coming.
I'm Blake Daly. Great to be here and pumped to build some companies out of this.
We have goals. We have big goals here. So, today at a glance, it's going to be a really, really fun full day. So this morning we're doing our opening, and then we're going to be sharing the challenge briefs. Although the developer guide and the challenge brief, the link is available on the Luma page if you register. It's also available in the Discord, or maybe we'll share it on our Discord as well. Then midday is pretty much build day, or the building section. So you're building with clinicians and mentors are going to be around to answer any of your questions. So let's say you have a question about, hey, I'm thinking about adding this new feature. It's going to take me maybe an hour to build. Is this useful for you? Or, oh, what is your real pain point? Is this solving your pain point? Then afternoon, continue building and refining, and then at the very end is closed, demos, and clinician judging. So the projects are all going to be judged based on clinical importance, innovative use of AI, and responsible AI. So a little bit more detail about the run of the day. So we are currently at the opening remarks, and then soon after we'll have a physician panel and Q&A where you have the opportunity to ask the panelists all sorts of questions. Then after that, we'll have team formation and idea lightning pitch. So raise your hand if you need a team. Cool. Okay, awesome. So this is going to be an opportunity for you to find your people, find your team to work on your projects. I'll share a little bit more about the name tags you have. So we'll have there. Then lunch, 12:30. Then dinner and submissions close. Remember this time, 5:30. From there, we'll select the finalists, and then presentations will start around 6 o'clock. Then after that, after the presentations, we'll go into the award ceremony. Now for the prizes, we have a lot of really cool prizes for you. So one is a $1,000 prize for responsible AI, sponsored by Telus and Alspar. It's for the team that best builds AI that's safe, transparent, and keeps clinicians in the loop. Then there's most innovative use of AI, also for $1,000. So that's sponsored by Clinician for the team that applies AI in the most original, creative, or unexpected way to a primary care problem. Then clinical workflow excellence for $1,000 for the team whose solution most meaningfully reduces the administrative burden of the primary care team, sponsored by Telus. We also have these fun awards as well. So later on, you'll have the opportunity to vote on your favorite team projects as well. And this one is sponsored by Compounded. And also, here's another one. Typically, when we build in these hackathons, it doesn't just stay in the room. And really, it never just stays in the room. It goes beyond this event. It goes beyond just the people in this room, because what you're going to be building is very life-changing. So, we build in public. Social media award. Take photos throughout the day about your team's progress, what you're building, get your community involved. There's a prize for that, $375 for the team that best shares a project and events energy online. So make sure you tag, in order to win that prize, tag AGI Ventures Canada, and then hashtag hackers and healers, and hashtag AGIVC, and we'll be able to find your post that way. And now for the judges. Raise your hand if you are, raise your hand, judges. You're in this room. There we go. Ask some questions. So we have, so Tinello is not here yet. She'll be here later. And then there's Ugo, and then Arun, Zach, and Blake. And then next we have the mentors. So raise your hand, mentors, if you are here there we go. So if you have any questions during the event with anything at all, please reach out to them, and then if we can answer it, we'll find the right person who will. Now I'll pass it off to Zach.
Thanks, everyone. So I just want to talk a little bit about the backstory for this event. So my colleagues and I spent a lot of time thinking about how to implement technology technology and how to implement AI into healthcare. And we often use the example of electronic medical records, or EMRs, as kind of a cautionary tale of what we kind of want to avoid in the future. So EMRs were a technology that was thought that was going to save clinicians time, but it really did the opposite. And the big lesson from this rollout is that when we build technology without the input of the clinicians, but the end users, we can end up adding burden rather than relieving it. So now we find ourselves in this incredibly exciting new wave of AI innovation, and we want to make sure that we don't repeat the mistakes of the past. So there's three things that we think that we can do to support this. The first is by gathering the ideas and consensus from clinicians. So we've been conducting focus groups with primary care clinicians, and this is the information that's in your briefs from the Compass study. Then we need to bring this information from the clinicians to the builders, to the entrepreneurs, and that's what we're doing here today. So the clinicians have great insights into the problems that they're facing, the solutions that they're interested in. They may not have the technical pathways to implement those. And on the flip side, the builders and the entrepreneurs who have the technical side may not have access to the kind of the clinical context. So today's really meant to bridge that gap. And one of my hopes for today is that the clinicians and builders will be able to learn from each other and to kind of make lasting connections that last beyond the day. And the third thing we need to do is to support early stage startups. So healthcare is not an easy space to work in. There's a lot of complexities. There's a lot of barriers to adoption, but there are organizations locally that are available to help folks to scale their early stage startups, and we'll hear a little bit more about that shortly. But today's event really is a co-design event. We have clinicians participating, we have clinician advisors. We're going to hear from our clinician panel shortly. And periodically through the day, we're going to have more clinical folks and healthcare experts pop in, and you'll be able to run your ideas by them. But today is really about bringing people together and see what we can build. So whether you're coming from medicine or software or data science or entrepreneurship, thank you for being here, and good luck with your projects. And with that, I'll hand it over to Dr. Bruyère.
Thanks, Jack. I'm going to put a timer on myself because I can get very chatty. Okay. How's everyone? Excited? Yeah. Okay. I wanted to add one small thing to what Zach and Elda were talking about. We've got quite a few mentors, not beyond just the ones that are on the photographs there. You're going to see on the name tags that they've got a little blue dot. That means they are a mentor. And there can be mentors who are clinicians, mentors who have built companies and built tools for primary care or healthcare in general. So if you have any questions, anybody with a blue dot, ask them a question, okay? Okay, so maybe I'll jump into talking a little bit about, just introduce myself. So I'm a family doctor. I work with the University of Ottawa, the Department of Family Medicine. And I'm trying to bring a lot of those experiences to what I'm going to be talking about in the next couple of slides. I'm also an AI researcher at the Bruyère Health Research Institute, so it's an interesting little interplay for me to see this room come together today. So I'm going to start us off, like Zach gave us a wonderful intro around like why are we here, like what's the purpose, what's bringing us here. I'm going to get started with a little more context, right? So let's talk about primary care. Now, many of you, maybe many of you, have you guys heard about this crisis in primary care?
Yeah.
Yeah, I see lots of nodding. Well, what is this crisis? Well, one part of that crisis is that first stat on the slide, right? Your family physicians are spending 19 hours a week on administrative work, right? So that's not the work that we spend seeing people and caring for people. It's administrative. What is administrative is probably the next question you're going to ask, right? So when I say administrative, what it is like, it's filling out those forms, right? So you need a tax form to be filled, a disability credit form that needs to be filled, a requisition to a specialist that needs to be filled, a referral, I should say there, right? You need to do some billing items to reconcile for the visit to happen, right? So there's a lot of these types of activities that are outside of the care that we provide. So the next question you're asking is, well, when does this happen? Well, it doesn't happen when you're seeing your patient. not going to happen when you're actually providing that care. It happens afterwards. But when is afterwards? Well, for most clinicians, afterwards is after you put your kids to bed. Right? When you're in your pajamas and you're getting ready to wind your day down, you're on your computer, you're filling out those forms, you're making sure you're doing all the administrative tasks that you're supposed to. Right? So we see that this administrative work is increasing as time goes on. And why is it increasing? Well, healthcare, quite frankly, is becoming more complex. Health issues are becoming more complex. And with it, that administrative burden is only growing with time. So you can imagine that 19 hours is now, it will only get worse as time goes on. So that brings us to the next stat on that page. So we're now seeing that close to or over 50% of family physicians are reporting symptoms of burnout, or quite frankly, are burned out. Right? And these are not unrelated issues. Right? When you ask clinicians who are burning out, one of the biggest challenges they are facing is because of that administrative work. It's not necessarily fulfilling to do that work. That's not what people got into medicine to do. They wanted to be interacting with people, not filling in forms. So that's part of the burnout story. Right? Which then brings us to the third piece, which is the crisis that we started talking about. So 20% of Canadians don't have primary care. They don't have a family doctor. Why is that? Well, one part of the problem, not the whole part, but one part is that we're spending 19 hours a week or more on administrative work, and so there's less time and less space in our days to be able to care for more patients. Okay? We're also seeing that as clinicians burn out, they're also able to see less patients. And in fact, many of the people who are burning out are just walking away from their careers altogether. So this is the problem. This is the challenge. This is the context. Which then brings us to the opportunity, right? And that's what the opportunity is. We understand that challenge now, and AI is that opportunity to be able to address the challenge that we're facing. But there's a caveat. Only if we do it in a way that's going to be helpful for the people who are doing the work. So how do we build those tools to be helpful for the family physicians? We know that the family physicians are under strain. We know that AI tools can offer an opportunity to reduce some of that strain. But we have to also be cognizant of issues that have happened in the past. And I'm going to bring up a small point that's backing up, which is around the EMRs and the electronic health records. Were these built for family physicians and clinicians? No, they were not. They were built for the healthcare system, right? In fact, when we look at the introduction of EMRs, we are now seeing 90% of family physicians in Ontario, over 90% are using these EMRs, but they're also reporting increased digital burden from these tools. These tools weren't designed to work for them, right? And that burden is real. So when we are now talking about the next generation of technology, digital tools around AI, this is our opportunity to take a lesson from what we learned with EMRs and build this with clinicians and for clinicians. Right? So that's our opportunity, and that's the risk. So that's what today's about, right? It's about trying to make sure we take this opportunity, but downplay the risk by bringing us together in the room, right? So you as developers and innovators in the same room as clinicians, so you can hear and understand the challenges that they're facing and design solutions, hopefully together. Okay. So in order to give you a little more sense, I'm way off time, guys, so I've already gotten very chatty, but I'll keep going. So I'm going to tell you a little bit about some of the work that our team has done over the last 6 to 8 months, which is trying to understand what clinicians have told us around what they want to have built. So really, at an overarching side of things, what we're seeing is that clinicians are telling us, right? So we talked to many clinicians here in Ontario, in the Ottawa region. Clinicians are telling us they don't want AI to replace them or to replace their judgment. That's not where they are right now. They want AI to be able to help them do their work, make their work more doable, right? They want AI to reduce these repetitive tasks. They want AI to help them, support them in preparing to see their patients, right? And helping to follow up on their patients in between care and in between visits. They want AI to help them understand the totality of their patient's experience so that they can provide better continuity of care. That's what we've heard so far. So let's get more granular. So we've heard about 6 key areas that people are interested in seeing AI being implemented, right? So the first one is in pre-visit preparation, right? So tools that can scan the medical chart, identify what was discussed in the last visit, perhaps even summarize what's happened between visits. So for example, if test results come in, summarize all of that and have that ready. It's a little note for you or a little bit of an intro before you go in to see your patient or why you're seeing your patient to help you make sure that you cover all the key things, right? So that's what people are looking for. In the visit, they're looking for some encounter support. So yes, maybe you're discussing a topic. Maybe there's something around diagnosis or maybe around treatment options, maybe around investigations. You want the AI to be able to say, you know what, maybe you want to consider this, maybe you want to consider that, based on evidence that's already there. So we want that kind of decision support piece there. We want some support along medication and prescribing, right? Like what kind of medications could be prescribed for this patient, what might be medications you want to avoid because of interactions, what kind of coverage is available for the patient, so we can make the right choices there. After the visit, we're looking for tools that are going to help us to understand, well, okay, did someone get their blood test done? Did someone get their imaging done? What was the outcome of that? We want some kind of summarization and follow-up to make sure these things are happening. We want a lot of help around admin and coordination, right? So all this information comes back to us, right? Test results and reports and requests for forms, all of that comes back in, and we need some help with inbox management. And then lastly, we want to know more about what's happening with the patient beyond what just happened in our clinic. What happened with other visits that they had with other healthcare providers? What about your own personal digital health information? Maybe we would like to know more about that too, in terms of what's been happening with you. So when we went back after talking to clinicians, and we also talked to medical AI experts, we reflected the same things, right? So digital medical office assistants were identified as being important. Inbox managers, as I've described, ambient scribes, so scribes to help with transcription of conversations, but also little prompts with decision support items. Pharmacy agents to help with decisions and ideas around medications, and then triage, right, and self-management tools. And triage is really about understanding the urgency of what someone needs in terms of help and trying to help prioritize and make sure that comes up higher up in terms of when somebody's seen. Okay, so with that, I went way over. Sorry, Blake.
You're perfect.
And we're off to you.
You're perfect. Good job.
So knowing that we want to build meaningful solutions, I'll say the quiet part out loud. This is a massive economic opportunity for people who want to build startups or companies. Canada spends about $400 billion a year on healthcare. So to put that into context, it's about 40% of public dollars or tax dollars towards healthcare. This is only going up every single year with just inflationary costs. So when we look at the current stress of how many people don't have family doctors, that is only going to increase on our current trajectory. Every challenge here presented is a commercial opportunity. The question is, how do you make that user experience something that the person actually wants to use and that they get back time in their life? At Bruyère Health, where I'm the lead for innovation, we prioritize Canadian-built health technologies. So we evaluate and adopt about 3 to 5 new Canadian solutions a year, and that's something we're really proud about every year. Building these ventures helps improve lives and the broader Canadian economy. So it's not enough to be Canadian and say, well, healthcare should be free. We all agree to kind of the principles of Canadian healthcare, but within that, you have to look at everything in healthcare is purchased. All of our electronic medical records, all of our tools. So don't be shy to say you're building in the health technology space, and don't be shy about saying this could be a commercial venture. After today, there's an ecosystem in this room and in this city that's there to support you. At Core Innovation, which is a collaboration between CHIO and Bruyère, we run a health tech incubator called 880. We're helping people cross these bridges between the different verticals or the different spaces that typically don't talk to each other. Healthcare typically doesn't talk to the researchers as much as they should. Researchers don't talk to the business community. And with that, we have very little overlap when it comes down to how we can build companies that drive real impact on the front lines. So this is something we're doing at Core Innovation, and we invite you to get in touch with me or the Core Innovation group after this event. With that though, we're part of a much broader community in Ottawa. I'm really proud of the community we built here, and I think that you live in one of the best cities in Canada to be a builder in the healthcare space. So at the top we have 8 to 80. We also have where we are today, Invest Ottawa, LSpark, U Ottawa, and many others. And then on the national front, we have groups like the Can Health Network, Obio, MyTax, OCI. All of these groups are there to support Canadian ventures through the valley of death towards commercialization and the changing of lives. So with that, we're going to have a brief conversation with the panel to get more feedback about what their lived experience is around these healthcare challenges. And maybe we'll jump into some Q&A from the room quite rapidly and get on with the hackathon. So I'll invite up our panelists. You met Arun this morning. Kiera Milandalin, medical doctor, family physician. Mark Nazem, family physician at the Greenboro Family Medicine Clinic. And Yubin Lee, a recent med student grad who will now be doing residency in Ottawa. So congratulations. I thought we'd do a couple of questions and then really open it up to the room so we can get folks on their way with some building. So the first thing I want to build on, Arun started to mention this, but what does administrative burden look like for you in your day-to-day? Maybe starting with you, Mark, what does administrative burden concretely look like for you? You wake up in the morning, show up to work, what's it look like?
Yeah, it's either. Basically, it's largely inbox management. So drinking fire through a fire hose of documents that incessantly show up in my inbox. That's probably the number one thing.
That's a visual. Yeah.
So I agree with, is that, hello, no? What's wrong with me? Do you hear it? Yeah. Okay, sorry. I agree with you, inbox management for sure, but specifically also repetitive tasks that don't add any benefits to patient care. For example, if I send a referral somewhere and then it bounces back saying you had the wrong form, you used the wrong portal, which I have like a million passwords that I never remember. So it's just those added steps that you need to do again that don't actually add any benefits to patient care.
It's a constant friction that's just nagging all the time. Ruben, you kind of alluded to pajama time and missing time with your family, but anything else in your day-to-day practice?
Well, I think we're focusing on administrative burden, right? It's a key thing, or are we looking beyond that as well?
I think just, yeah.
Yeah, so I might say the other piece is that, as healthcare has gotten more complex, what also is overwhelming is it's hard to even keep track of the resources that we can recommend or suggest to our patients, right? Like, what's out there? It's hard for me to keep track of everything. Things are growing in such a rapid pace, so being able to navigate the system and understand the resources that are out there, that's also a big piece. That is a different kind of administrative burden, right? Being able to keep on top of that. It's hard to sort of sit there, I'm gonna be sitting there in my kids playing their hockey game and be on my computer trying to navigate and figure out, well, what resources are available. That takes up a lot of time. But that's something that's also, I think, a challenge that we face.
And maybe building on that, Yuda, as a recent grad moving into the health system, what are you and your colleagues talking about for the future of healthcare?
As a medical student, your entire focus is medicine, right? Like patient care. How can I become the best doctor I can be? But we're never taught about any of this administrative burden. And so I'm sure in residency, maybe you're introduced to it a little bit, but then you're kind of thrown into the real world of how do I run a clinic? How do I manage my own practice? And I think those initial years of transition, it's not really talked about. It's not taught in medical school, and that whiplash can cause a lot of burdens, especially in the first few years.
Okay. And maybe quickly, I know, Mark, we were speaking earlier about your practice is quite technologically forward. Can you speak about some of the tools that you are using that are promising and maybe ones that you're exploring?
Yeah, for sure. So I introduced my group to the medical AI scribes a couple of years ago, and I can say that it has reduced my administrative burden by about 25%. So, and prior to that, I was using voice dictation templates and the search and destroy typing because I'm a terrible typist. So that made a huge difference. And even my most efficient colleagues agreed that that was a huge win. So that's been big. The other thing we recently implemented, as literally last Friday, a medical AI inbox manager, which basically takes fax documents, reads them, labels them, sorts them to the appropriate physician, can even flag, an urgent mention or something. And so we're literally in the midst of trialing that.
Any other technologies that the group are excited by?
So when I was on my family medicine rotation in third year, I was rural. I was in Barry's Bay, if anybody's heard of that. And with my preceptor, we stayed up until 11 p.m. and it was a Friday night, not seeing patients, but doing his billing. Because if he didn't get it done by midnight, he would lose over $10,000. And in family medicine, please correct me if I'm wrong, the cycle's every 3 months. If you miss that deadline, it's very hard to get that money back because you're not paid on a salary basis, you are paid by what you bill. And seeing that, I was like, oh, I don't want to do that. But I'm a doctor, and so that's just one area that I tried to tackle throughout my medical school career.
That's exciting. Something you said, yeah.
Can I just add on that? Sorry. Billing is super complicated and changes all the time. And if you don't know what codes to bill, you miss out on a lot of money opportunity. So just learning how to bill, and that is applicable through all the specialties, not just family medicine, is a huge burden added, and it takes a lot of time. And usually, recent grads miss out on money because they just don't bill efficiently.
Just a quick comment to that. So it's literally the blind leading the blind. So you rely on your experienced preceptors who may not actually know. And so the billing guide, just to give you, which is publicly available, is 900 pages long, fine print. When I graduated from residency, back in this paper, they mailed me a box with that binder, and then they mailed me another box with the revisions. That was like 2/3 of the binder, and I had those abilities to share. So that's just using an example of the disorganization. And you can miss huge amounts of billing thinking you're an expert, and 10 years later realize you missed code.
So, wanting to get to the room for questions, last thought here is, Arun, you mentioned the health system earlier. And all of the tools that the group has talked about right now doesn't come from the system. There's no one at Ontario Health, sorry to be the bearer of bad news, who's leading the way on new technologies and trying to drive outcomes for clinicians and patients. It's awkward to say, it's kind of scandalizing to acknowledge, but it really is the builders who are driving the future of technology adoption within the Canadian healthcare system, and are a huge part of the opportunity to actually get access to care and save lives and potentially even improve collective population health. So with that, I'd love to offer back to the room, just recognizing time, to ask our panelists questions as you think about what solutions you want to be building today.
Can I borrow?
I can do some running around.
Hello everyone. I had a question, I guess, around billing. Like, what does it really look like for you to go through the process on, I don't know if it's day-to-day or like quarterly, and I guess what are the tools that you're currently using for that, other than the big booklet?
I can speak to that because I trained our office manager how to do the billing for our practice manager. She's way better than me. So at the end of the day, when you've completed your notes, or at the end of your encounter, whatever your preference is, you enter a diagnostic code, which indicates patient cited for pneumonia, whatever, and then you enter service codes. Those service codes are based on the nature of the visit and the service you provided. So most service codes would be something called an intermediate assessment, or an A007, which is a typical doctor's visit. Added on if you drew blood, if you did a urine test, did an EKG, or whatever else. So that's the bricks and mortar of it. That's submitted through a batch file, either at the end of the day, or at the end of the month, or at the end of the week, depending on how you like to submit to the Ministry of Health. That's done electronically. A reconciliation, a confirmation file is sent back saying they received the file, and then they'll send a reconciliation report, which is like, you tried to bill a pap test for an adult, for a male, you did a mistake. They go, so you get that back, you correct it, or your billing clerk corrects it and you submit it, and that goes back and forth. Just to reflect back to you, doctors who don't reconcile their file lose about 10% of their gross billings per year.
It is extremely complicated to reconcile your file, and you just might as well just work another day and see patient. That's my philosophy.
I saved my practice literally $50,000 when I first started, just because of the lack of reconciliation. So it all depends how much you work.
Hi, a couple of questions. We know that healthcare is a highly regulated space, and so my question is like, once we build a prototype, once there's alignment, there's value in it, what can we expect in terms of the regulatory hurdles that we have to go through in order to see this system actually making life easier for clinicians? And what is the time frame typically for that? That's one. And the second one is, as we build for like family clinics, primary care, like, does the clinic operate pretty much the same way, like relies on the same set of data sources and procedures, or like, what do we need to take into account to build for the 80%, for the majority of the users?
I can take the first one. When you are building a product to be patient interfacing, it has to be incredibly secure. I think that goes without saying. The regulations that, at least at our startup, that we focus on goes from HIPAA, and because we want to expand into the US, we also accounted for HIPAA. And eventually, if you want to sell to larger institutions like hospitals, or even want to do research studies, you have to have SOC 2 certification as well, with third-party auditing included. And most of those regulations revolve around the identification of patient identifying information. Is all of your data stored in the country? Will it ever be transferred outside of the country? Can't happen. And there are set guidelines that you can find online to make sure that you fit within those guidelines, at least for the data and HIPAA.
So I would say, for the second part of your question, most primary care clinics will have a very large but similar scope of practice in terms of the things that they do, the things that they bill, the regulations that they follow. So it's very large because primary care do a lot of things, but most of us will do similar things within that big pool of things. Very big.
But ultimately, if it helps, the life of a doctor, patient interview, so scribing and entering data, and then processing data, either organizing tests, following up on tests, submitting billing, all done within something that is PDFA compliant.
I think just for the question you're asking maybe driving towards where's the data or what kinds of data are we looking at, right? I think that's the second question. So a lot of the data sits within the electronic medical record. So some of it's going to be structured data, some of it's going to be unstructured, just text data, free text. A lot of it's free text. That's the clinical encounter. The structured data is going to be things like lab tests, lab results will be coming in as data points, potassium number, right? That's how it'll come in. You can work with the EMR data directly, or you can work even like with the Telus, with the Ontario Lab Information System. So lab data will come in that way. There's similarly radiological data that comes in like in that fashion in a more structured manner as well. But there's also a lot of data that's going to come in that's just text. It's like just pages of text that get scanned into charts or basically scanned into charts. So there's going to be this very sort of loosely structured data from that. So I hope, does that help to answer your question?
Yeah, thank you. We've got one over here and then one more question over there.
Yes, thank you. I think you partially answered my question already, but Dr. Hill was mentioning that there's many forms to fill out, and sometimes you fill out the wrong form. How many of these forms are paper forms that you have to fill out, and how many of them are EMR things that are passed electronically to the next specialist?
I'd say it's about half and half. So a lot of the paper forms are usually sick notes, hospital employment form, insurance forms, things like that. The disability tax credit, you can fill online. It's a little complicated, so sometimes I'm just like, it's easier to do it on paper. And then I was referring to like referral to specialists. So typically, I would write a letter that contained all of the information that the specialist needs to triage and consult, contact the patient, the relevant medical information. And then sometimes they will say, no, I want it in this specific form that you have to download and print, or it's on Ocean, which is a portal that some specialists are on, not every specialist are on. Sometimes they will say, sorry, I don't see this type of issue, so you have to find someone else. And then you're like, how do I know? Like, they're all ENTs, for example, but they don't all see the same type of problems, but I don't know what they want to see. So, like, I'm spending so much time and it doesn't add any value to the care.
There is an initiative that exists right now called e-referrals, and they are moving towards standardizing all these different referral forms and requirements to submit through an online system to specialists. And then another thing, so one of the things that many doctors will do, or some doctors will do, will take those paper forms, convert them electronically, and then type on them. So we're in essence reinventing it.
Hello guys, so I know how hard it is to adopt AI or anything AI related into say government, right? Because it has a lot of issues. And when you need to do it for many people have to resolve all those issues like privacy, don't input sensitive data or patient data that you're not sure about how it's going to handle if it's not found locally or all this stuff. So say by the end of this event, there's some solution that's some team provides and you really like how you solve your problems. How are you going to proceed if you want to implement something?
All right, who's excited? And so before we announce the finalists, and by the way, thank you so much for your patience. We just want to let you know that there was a lot of thought that took place across, I think, 44 projects. So very, very competitive. So before we announce the finalists, we're gonna share, we have Nello presenting about Compounded first and what they've been doing. And then also Shannon will be presenting about Invest Ottawa.
All right. Hi everyone, good evening. It's been a very long day, so I'm going to be very brief. My name is Chinelo. Most people call me Nello, in case you hear that somewhere. I own Opal Wellness Compounded Pharmacy. It's a pharmacy in Ottawa here, but I'm also co-founder for Compounded, which I'm going to speak about this evening. So how many of you know what compounds are? Compounded medications? Okay, good. So people know, because every time I mention compounds, people don't know what I'm talking about. Compounds or compounded medications are basically custom-made medications. They're medications that are made by hand and are made for a specific patient for a specific indication. So it could be like a different dosage form that's not available commercially, a different strength that's not available. There are just so many use cases. But compounds generally fit a very essential gap in our medication supply chain. But what that means, given that they're custom made, is that mistakes can be very unforgiving. So imagine picking up a medication that could basically kill a child and substituting that for something that was on the prescription and not being able to identify that until the risk gets to the patient. So it's a very, very, how do I describe it? It's a very, very risk-prone process, and we need to put in safeguards to ensure that compounding pharmacies are actually doing the best that they can to provide high-quality medications. So what happened in Canada a few years ago, the bar for compounding rose. So there's a body called NAPRA, and they regulate or provide or prescribe guidelines for compounding. So sterile compounding, non-sterile compounding, hazardous compounding across Canada. And what happened is the provinces of pharmacy across Canada adopted those guidelines. And many pharmacies had to drop off compounding as a service because they couldn't meet up with the new regulations. It also meant that people had to make lots of investments to make sure that their pharmacies came up to par with the new regulations to continue to provide safe and effective medication. Every pharmacy, regardless of what kind of compounding you do, has to make sure that they are abiding by these regulations. But with the bar becoming higher, no tools actually came into the market to help compounding pharmacies meet those regulations. And what that means in practice is you walk into a pharmacy and you see stacks of binders filled with paper where people are taking down notes, jotting down numbers, and that's how they come up with formulations that go into the medications that are produced. And you might agree with me that that process is very, very flawed. So getting into compounding myself and owning the compounding pharmacy means that I carry a lot of risk. And that risk applies whether I'm in the pharmacy or whether I'm not in the pharmacy. And I had to think about a process to make the workflow consistent every single time and make sure that the compounds that are being produced in the pharmacy are not dependent on the hands that are actually on the bench. And that comes from making the compounds myself and seeing how mistakes can be made and making sure that they're not carried over to the patient and potentially causing risk. So we built Compounded, which is a compliance platform that ties in every single component that pharmacies need to stay on the good books of regulatory authorities. But we're not just focusing on being compliant as a check mark, it's actually helping you integrate all of these steps into your workflow. So taking away manual calculations done with paper and pen and a calculator on the side, and giving you standardized calculators that do calculations for the most complex dosage forms, suppositories, capsules, troches, whatever, you name it. Making sure that you have something, double checking your calculations, double checking your logic throughout the process, and highlighting where mistakes could happen or presenting errors to you so that you can take action. Including things like making sure that you're being compliant with all the paperwork that your regulatory authority needs to see when they come in to do an inspection. So, like I said, intricate calculations, everything done right, double checked, beginning things like UPC verifications. So most times when the public hears about compounded medications, they'll hear about it when something has gone terribly wrong. And you will be told that somebody grabbed the wrong medication and the child died. So we're beginning things like UPC verification, making sure that whatever I have in my hand is actually what needs to go into the prescription. Things like skin integrations as well. If I take a measurement for an active ingredient on my scale, the scale can transmit that value into compounded, and that means someone is not forging up numbers. And if I tell you that this is a 10% cream, then it's actually a 10% cream. And also photo capture, so documentation that persists after the compound has been consumed by the patient. And this is important for risk management with the pharmacies. If someone came in 2 years from today and says, well, that cream you made for me 2 years ago, something was wrong with it, it wasn't the right medication, I do have evidence saying that this was actually what went into the product. So giving pharmacies back that autonomy and peace of mind when they dispense medications. And again, inspection ready at a glance. So not just external inspections where you are telling someone from the Ontario College of Pharmacists that you are compliant, but internal inspections as well. As a pharmacy owner or pharmacy manager, I want to make sure my staff are actually doing the things that they need to do. So every time I log into Compounded, I can see where there are flaws, I can see where there are gaps and where we need to make improvement so that I can take corrective action before it becomes a downstream problem for my patients. So how did we come up with Compounded? We found the problem. Owning the compounding pharmacy, doing all that documentation, realizing that this is work that I'm doing happily because I own a pharmacy. However, how do I make sure that staff who are just working for me would actually do this and be diligent about it. And it's easy to give someone a job and say, you go do this, but you need to empower them with tools that actually make sure that they can get the job done. So that was where we found the problem. And then the second thing was we went ahead to decode the regulations. This is the biggest part of solving the problem, actually going in, understanding the regulations line after line, word for word, and translating that into the technical, the program or the software that you see, but also making sure that it fits well into the workflow, because many compounding pharmacies have been operating for decades, and if you brought to them a tool that changes their workflow fundamentally, it just wouldn't fly. So doing that, and also thinking about how we engineer the hard parts, so system security, HIPAA compliance, and also usability at the desk, which I just described. And then our go-to-market engineering, ensuring that we are tailoring our sales process and engineering the sales process to fit how we sell to compounding pharmacies, so that they have the time to actually analyze, evaluate the software, and uptake it. So Compounded we opened our doors in March this year, and we've already seeded in many compounding pharmacies across Ontario, and we're excited for the growth. And that's why I'm excited to be here today. And good luck to everyone who has taken time to build something that could potentially change how we deliver primary care in Ontario. Thank you.
One of you? Either one. Who wants to go next?
Hi, everyone. First of all, this is such a great turnout, and we're so happy to have you here at Invest Ottawa today. I want to start by thanking AGI Ventures for bringing everyone here, and I have a quick question for you before I introduce myself. Who here, of course we're at Bayview Yards, but who here knows what Invest Ottawa does? Okay, awesome. Well, I'm Shannon Ferguson. I'm the Senior Manager of Early Stage Programs here at Invest Ottawa. And at Invest Ottawa, we are actually the lead economic development agency in Canada's capital, so right here in Ottawa. And we help founders and technology companies build, grow, and scale successful businesses. So through the IO Venture Path, we help entrepreneurs really accelerate their journey from idea to scale. So there's probably been so many great ideas here today. And in fact, what Invest Ottawa does is really help companies take those ideas to the next level. So what the Venture Path currently supports, we currently support more than 600 companies across a really wide range of growth stages, from founders that are just validating a new idea to scaling technology companies that are generating over $100 million in annual revenue. So our goal is to simply meet founders where they're at, right where they're at, provide the support they need, resources, expertise, connections at every stage of their journey. So I'm going to tonight highlight two of our programs, so IO Ignition and IO Flex. I may know already by the show of hands before, but who here has heard of Ignition or Flex? Okay, awesome. Well, for those of you who haven't heard of Ignition or Flex, you're going to right now. So Ignition is our 10-week startup bootcamp. So it runs every quarter. We're actually starting a new one in a few weeks, and it's really designed for founders who have an idea and they want to validate it. So through customer discovery, mentorship, practical startup training, participants, they really learn how to test their assumptions, refine their value proposition, and build a strong foundation for a tech company. And then once founders, they've found that foundation, a lot of them continue into our Flex program. This is more self-directed. It provides ongoing access to advisors, business resources, workshops, events, and really the broader innovation community that you'll often see here at Bayview Yards. If you're ever here through the week, it's pretty cool to see. So if you're wondering where to start, you obviously all had great ideas that came up today. If this is something you're thinking about really taking to the next level, you can visit the IO Venture Path website. There's actually a quiz on there that you can take. and it will let you know what path you should really be looking at. So please do that. I'll be around here if you have any questions as well. But thank you again, AGI Ventures, and I look forward to chatting with any of you who have more questions. Thank you.
All right. Hello. Good God. Great turnout. ELSpark has been around for 12 years right now. We are based in Canada. We have been backed by Wesley Clover, which is our local family office in Canada. And the first 10 years has been all about growing companies, helping founders grow, helping build a plan, raise money, and introduce founders to customers. We changed. 2 years ago, we changed, and we do the same. We continue helping founders, but we partner with strategic partners. Today, one of our partners is Telus, and you might ask, tell us more. And so what do we do with Telus? We have lots of GPUs, and Canada needs GPUs. And if you think about it, in the financial sector, AI trades with AI. Drug discovery needs GPUs. And so we need to make Canada stand out. And so Telus is our partner, and what we do is every company that gets selected into the Telus program receives mentorship from ELSpark. And today we run our first cohort of companies. We have 5 companies, and these companies have received GPUs, and they are working with us to raise money and to grow their business. So if anybody is interested in talking to ELSpark, please see me after the speech, and good luck.
I want to say thank you again to our sponsors. Without them, we wouldn't have all these amazing prizes. All right, now for real. Here are the finalists that are going to be, so if you get called as a finalist, you need to be ready to present right after, so just be ready. For the most innovative use of AI, the finalists are thread care, fast triage, and intake inbox triage. So if you're ready to present, line up here in order, and or just be ready. Next is clinical workflow excellence from Tali, $1,000. And the finalists are Charted, an EMR analysis helper, Bobby, Function over Forms, and CDoc. Now for responsible AI, by Telus and ELSpark. The finalists are fast triage, intake, inbox triage, and AI clinical pharmacist. All right, so first team coming up is Thread Care. And also for the presenters, just to let you know, I will have a timer. You'll have 5 minutes. 3 minutes for presentation, or at least this is the suggested allocation. 3 minutes for your presentation, and then 2 minutes for Q&A for our judges to ask you any questions.
People are here, and Telus are here. Choose. Okay with you? Where do you want us, the judges, to sit?
Yes, fine.
We'll sit there if you want. Okay.
No, those are the finalists for now.
Did you guys announce the finalists?
Yes, we just did. So where's the
Team Red Hair, are you in the room? No? Red Hair? Okay, so in that case,
Someone gets bumped in.
Yep.
all right, so I guess before we, all right, I just want to make sure all the teams are here. So Thread Pair, raise your hand if you are here, you are not here. Okay, fast triage, where are you? Awesome. And then intake, inbox triage, where are you? Awesome. Okay, so.
Yeah. I think that's fine.
All right, so since Threadcare is not here, the next demo is Checkley. Are you here?
Are you here?
Perfect.
Okay.
All right, you will be up here. All right, fast triage.
I thought I'd have 2 minutes, I guess.
Oh, what? A microphone for the workers? Yes. I'll have one here.
It's there in front. Can you give me some other slide? I can plug it in.
Oh, did you want it?
Oh, yeah.
Yeah, are you going to
Good evening, everyone. This is a surprise. I really didn't expect to be here, but thank you so much to the judges for giving me the chance. Quickly, the doctor is here. I had a chance to talk to Dr. Aaron this morning. He said you get 150 messages a day in the inbox. The inbox looks like this. There are notes, there are referrals, there are urgent care reports that he needs to see, and he has to go through all those 150 emails in the day. The 149th email could be that of a heart patient whose report says they had a silent heart attack. If he doesn't get to it on time, there can be very critical consequences for not only him, but a lot of people involved. So Fast Triage takes care of that. It's an AI layer built into the system on top of the current EMR. This inbox turns into this. A simple, what is at risk? Critical things that the AI figures out. Say a lab result. The panel, there was an issue with the panel. It was flagged critical high. He can quickly select this, then look at the source document and open that file. Okay, what's the result? Why is it critical? Similarly, look at the patient medications, and along with that, there's a list of AI prepared actions which he can review and approve or modify. Along with that, it adds a small task list. He can just quickly click a button, it gets added to his task list if there's a follow-up. Now the next thing, how many times you've gotten a referral, 10 days later, you find out that doctor is not supposed to be the specialist you have to see. That's another problem that was surfaced when triaging. So referrals is a filter in itself. That filter, you get the referral, sometimes say if it's a cancer referral, in 2 weeks. Now cancer is critical business. If you end up seeing someone, you want that they have all the reports. They have a CT scan in place, they have blood work done, otherwise you're clogging the system and not getting the care in time. So this system, you simply select. Here also, it clearly tells you why a referral is accepted or it's not accepted. At the same time, it's learning. So if for any reason you're rejecting it, you can add a rule here. The system, so every clinic has their own rules. So you can add the rule that, okay, we need blood work, we need this, we need this. The system will learn as it goes. They can add a rule. For this rule, we are rejecting it. And AI does recommend, like here, it clearly shows this bariatric surgery, the referral disposition is accept with a confidence level. So every AI decision comes with a confidence level. If AI is not very certain, it will flag it. And that's the whole process. Thank you.
So I really like the use of the confidence level. Can you speak more in terms of how you're going to go and ensure that it really is safe? Because one of the things that AIs are really good at doing is appearing to be confident when they're actually making shit up.
See, the first layer is the reference material. Everything is right there. Initially, rather, I would have a badge here for at least the first 6 months to 1 year that please make sure that you're checking everything manually, at least not 6 months, but a pilot stage where the system is improving. They can, like, if you have deny, the output is not good, they can flag it, the output is not good. That's how I would go about it, so that the system trains and we get a quality metric that it's working or not. That way we can adjust the confidence level as well and long-term train the system.
I have a question. Yeah, over here. Really great job, by the way, bringing the people together. How are you grounding your AI agents in terms of how it's making these decisions?
So there is where I'm looking at a keyword match, a deterministic path, as well as a probabilistic path. So it's cross-checking against both. So we are trying to do both, a deterministic, a heuristic, like with keyword matches, but at the same time with an AI model as well, cross-checking it. That's the basic grounding that I have figured out for now. As I said, it goes with the confidence level where the data long-term, I'm hoping would improve this.
So the confidence level is based on like the AI's interpretation of its own work.
It's on interpretation and the training data that it has and the past context that it has gathered.
All right. Good. Thank you.
Thank you.
I just have a small question. How do you expect to get access to the inbox from, let's say, another EMR like Epic, Accuro, or Oscar Pro?
I'm pitching this as an add-on layer on top of what they have rather than like getting a separate system. I'm pitching this as an add-on layer onto that, so the data is being fetched through their system and it stays within their systems. That's how I'm pitching it. Thank you.
Thank you. All right, intake.
Hello everyone. So as also the last project, we also have a inbox triage management system. This also sits on top as an AI layer on the current mailbox, and it uses a classification model in the backend to classify these emails as urgent, as time sensitive, and as routine. And then it puts the time sensitive in the middle, it flags the urgent on top, and it shows you a confidence score. So this confidence score is based off of the classification model we have, how confident it thinks the urgency is. And then on the left side in the views, you can see it also, you can see views based off of if it's urgent, if it's awaiting triage, and if it's already flagged. And then in here, we'll show you how it works in the backend.
So now we're looking at the individual thread view. So I'll just walk you through a little bit of what we're seeing. So on the right side, in actual production, we would want this to be a live view of the EMR. So it would be very easy and all embedded in the same system for a healthcare practitioner to make edits to the EMR, and we'd be able to auto-populate certain fields in that smartly using the thread and the data that we have access to. I also wanted to go a little bit into some of the inspiration behind this. I don't know if anybody here has worked before as an IT help desk technician, but one thing that I found navigating interfaces like that is how so many other departments could benefit from some sort of triage system and shared inbox that adds a lot more status features and just smart classifications to save time and such. So this was a lot of the thought behind when we were building this idea out, and it really saves the doctor from having to look at things that are all the same size and nothing is flagged as something that they really shouldn't be looking at. So yeah, in our case, the classification will let the doctor know if something is only a routine and it's something that they can safely ignore for a little bit or put off, all the way to the most urgent of requests. And with the tools that we have, leveraging big LLMs, it also, in its current state, helps generate simple AI responses to that based on the thread provided. So yeah, it's a very early work in progress, but excited to see what afterwards. A lot more features that we had in mind that we could build into this, and this really is just the foundation for a whole lot of other future modules to come. So yeah, that's all. Thank you very much.
Have you given some thought to going and giving a means for the doctor to go and express their preferences? Because you've got a classification in terms of urgent, not urgent. How would you go and imagine going and allowing doctors to go and express their preferences that would go and complement what they
Yes, they would be able to add the preferences. This is not going to do that right now, but it is a work in progress. And that classification model actually learns upon what the doctor says, what the doctor prefers, and it picks up on his writing style. So any accounts locked in have different writing styles. So like if Dr. A has a different style than Dr. B, it would automatically recursively pull it up and learn from the doctor's preferences. Any other questions?
All right.
Thank you so much.
Thank you very much.
All right, Chuckley. There we go. Make sure you speak at the mic so everybody can hear.
Hi everyone, we're Shagri, and the problem we're fixing is when it comes to preventative care, what we found out when interviewing Dr. Sarah and Dr. Islam was that making our patients follow through on getting the things they need to do before they come and visit is one of the hardest problems that they're facing, and it also has a very aligned incentives setup. So the first incentive is that doctors are able to mitigate a lot of the overhead work they have to do on the administrative side by getting their patients to kind of just do it by themselves. And so essentially we came with the idea of a Duolingo-esque positive reinforcement platform for the patients to go ahead, be empowered to take actionable care of themselves through the platform after the triage has been done. So we would extract from the EMR systems the patient profile and what needs to be done for that given patient, and then transform it into a workflow and a kind of a street-like system for the patients to kind of like check box, okay, I need to get my blood work done for my colonoscopy, I need to do a stool sample, etc., etc. And all the while we have our doctor having observability over the patient before the next checkup appointment. So that's the problem in a nutshell. And we have other,
One of the biggest points with Checkly is to provide that continuity of care from once the appointment is completed with the individual, is to provide the patients a checklist on what needs to be done for their next appointment so that we can provide providers non-billable time and provide the patients a better outlook as to what they need before they come back for the preventative appointments. One thing that we realized through our conversations today is that many preventative tasks, such as immunizations, such as diabetes, has a tight incentive, not only on an institutional level, but on a provider level, to be able to ensure that these patients are getting back into the clinic. Our goal and our vision with Checkly is to provide that gap to one, allow the provider to see the patient in a much more faster and effective way, and two, to really bridge the gap in between the recommendations that are, or what we were told is the homework that is needed for the patients post appointment, so that they can come back and that they don't have to do any work again.
And speaking of the AI integrations, there's quite a few aspects we can do, or we envision. One is data intake on your phones, for example, the health app. Wearables are a huge thing, and these can give a huge insight into the clinicians on the status of the patient, as well as integrating things like forms from Life Labs or from other sources where you can submit your information. And this is kind of like a human in the loop, but also an agentic platform where we can monitor the status of what the patient has done without the patient explicitly having told the physician. And that's where we envision the product going. Yeah, that's all. Thank you.
Any questions? Okay, thank you.
Thank you, everyone.
All right, so that ends the most innovative use of AI. So next up, we have clinical workflow excellence. And before we start the demos, I just want to make sure all the teams are here. Charted, where are you? Awesome. Bobby. C-Doc, where are you at? There you are. Okay, Charted, come on up.
Times for you when they start. Sure. 2 minutes? Just 5 minutes. I'll just
How many, excuse me? Do you have a USB-C?
Yes, it's 2
There was no like actually
So, to all the doctors here, how often do you find yourself going through an EMR? And it does take a long time going through all the information here, which is why we created Charted. This lives in the browser as an extension, and it goes through the EMR and gives a summary of the information.
So lots of doctors are forced to use third-party apps or separate tools for going through EMRs with lots of data, such as ID. But we created a browser extension that eliminates the need for additional tools. You can just click Analyze Patient, and it'll go through the entire EMR and show you the information you need to better assist those in need. Just wait a 5 seconds. Promise, it's almost done. Okay, so firstly, and the most important part is the current visit. So it'll show the reason for the visit. So for example, Diane Tremblay, which is a fake patient we made up, has multiple chronic conditions. And you can see here, okay, so the flags for this visit are these 4 things. And then with that, it provides you some questions to ask so that instead of just reading off the extension and telling the patient what's wrong with them, it gives you opportunities to ask them questions and interact with the patient so they don't feel like they're just talking to a computer screen. And then if that's, we also have a full chart if you want to go further in depth, and it has a list of their condition times. So here you can see in 2011, this patient had hypertension, and then 2014 they had type 2 diabetes and so on. It also gives their lab trends, high blood pressure, high glucose, and then you can compare this with the lab trends. And then for further analysis, we can look at what changed since the last visit. This is also very important for helping diagnose what's wrong or what the patient has issues with this visit.
So on the technical side, when you click Analyze, what's really happening is we're first scraping this whole page, which we just made a mock of. So this is not using real patient data just yet. We just made a mock of what Oscar Pro really looks like. So it will first scrape all of that data, and since it's just scraping, it's all deterministic. So since there's no AI, there's not going to be any hallucinations. And then once it scrapes all the data, then the AI takes part in kind of summarizing all of this. It helps you see what has actually changed instead of going through all of this. We're currently also using Haiku to go through all of the text since we're trying to save tokens, and if a patient or a doctor wants to have faster results or even better results, they can change the model whenever they want. For example, when we used Sonnet, we found that the time of the response took a longer time. It took a minute, but obviously the response would be better, but we found that there was not much of a difference between Sonnet and Haiku. So to save tokens, we just used Haiku.
Yeah, Haiku took around 20 seconds to give results, which can be a lot more beneficial than 1 minute for doctors that are on a time crunch. Like, just to like doctors see around, I think, 30 patients a day or something like that, and primary care is very overexerted, and doctors are like constantly on a time crunch. And so looking through an entire chart with years worth of data is really not very viable. So having a tool like this that can help you quickly in like a minute or two before you see the patient, help you find what you need to best help them, and make sure there's no discrepancies, like if there was a missed blood work that was not followed up on, or a referral that was not followed up on. This can help you follow up with that, and then this can catch discrepancies in the EMR. Thank you.
Fantastic presentation. The window here, like how do you see the family doctor using this in their office? Like, is this before they go in to see the patient? While they're seeing the patient? How do you see this unfolding?
So, I believe that doctors have a minute or two before they see the patient. So typically what we imagine this would look like is that you would bring up the patient's EMR, quickly run this, and then look at the reason for the patient visit, and then before they come in, get a quick run through of why they're visiting and what can best help them in their visit, and that way it doesn't waste like 5-10 minutes of very precious time of the patient going like, oh, I've been experiencing this, I've had this in the past. It can help really cut through a lot of unnecessary talking and like get them the results they need.
I do want to add another way this can help family doctors is that instead of going through, again, what he said, going through all this to pinpoint exactly what they need to know for this visit, you can easily just look at this and see why. So even while you're talking to the patient, if they bring up a specific thing that they're here for, instead of going through all of this and finding, oh, maybe you have a headache because your blood pressure is high, you can easily just look at this and it will save time.
Very, very nice. One quick question around the scalability or maybe the cost of the economic model. Like how much would people take to scrape these stages, and what does that model break when data is all over the EMR and
So this, we can scale it to work with multiple, or like if you have everything in one web page. For example, Oscar has this, I don't know if it is like this with all e-charts, but Oscar has this e-chart all in one. There's one web page, and we just scrape the entire web page. If it's in different, like I know lots of healthcare is done with faxes and paper, and then that's something that we didn't have time to implement, but we would look into is using like something like Google Document AI, which can look through handwriting and then analyze what's on. So like say someone writes down, like doctor's handwriting is famously ineligible. And what Google Document AI can do is it can go through that and provide what it thinks is being said with a confidence interval. So it says like, oh, this patient has this issue with high confidence. Then you can be sure that that's actually what's said on the paper. But if it says low confidence, then you would have to review it yourself.
Thank you. Bobby.
Hello, hackers and healers. I have one question for each of you guys. Right here. Are you ready? Yeah. Bit louder. I can't hear you. We are here to introduce to you guys Bobby. Now, a bit of information right here. 20 million hours. Sounds like quite a lot. Well, Canadian physicians lose 20 million hours every single year due to administrative work. This is a study from the CMA in 2026, this year. And forms, they're the top administrative burdens. Disability tax credit forms are one of the most time-consuming forms with an average time to take, 37 minutes just to complete a single form. We want to save 8 million hours of physician's time with Bobby. Now, how does Bobby do it? Well, we've got a whole load of unstructured data. That includes transcripts, patient conversations, existing information about the patient. Well, Bobby is going to take all of that information and soak it up like a sponge. Now, let's take a look at how Bobby actually accomplishes this and takes unstructured data and outputs very clean, ready to submit forms. Let's take it away.
All right, so I'm gonna go through the workflow. It's super easy, 3 steps only. So first of all, you click on new form. Second, you choose your AI scribe. So Heidi, Cordy, any other AI scribe that you have. Second step, you choose your EMR. So Epic, Meditech, Oscar, anything that you're using. Click continue. And then choose your form. So for example, the T2201 Disability Tax Credit Certificate. And then you click fill. And you just let Bobby do the hard work. And it's gonna fill out all of the form. And you're gonna see the form visually as well. So we're gonna let Bobby do soak all the information and put it in here.
While Bobby is working on this, you're gonna see in just a second as the form generates. Some of the fields are going to be filled out, some of them are going to be left blank, as you can see over here. We didn't have an actual disability tax credit form to work with, so we had to use our own synthetic data for it. I'm gonna scroll down a little bit, but with the Bobby model, what we're looking for is that Bobby's only going to fill out what it can trace. So if there's traceability inside of the transcript, inside of the EMR that's able to provide concrete proof about in the background, then it's going to fill it out. So a lot of information it couldn't catch, while some here that are in the transcript is able to fill out. It's just for the demo purposes, we're able to demonstrate that. And then as soon as you're ready, you're able to share this. So for the disability tax credit, there's a doctor section and a patient section. So you're able to connect with the patient directly from within Bobby and the patient email, or if it's in your EMR, you're able to securely link it to the patient.
And then there's also a button to submit it directly wherever you need to submit. So this will say submit, and also this app will be in French as well.
So yeah, just to conclude, you guys, we've got tons of unstructured data. We want to distill it into forms that are ready to submit, only taking into account the real transcripts, the real audio, the real information the AI has, and not making any dangerous assumptions, and something that is very easily identifiable, auditable, and editable.
Go Bobby!
Go Bobby! Any questions?
Which, by the way, if you're wondering why Bobby, it's our CEO over there.
Eunice shows Bobby.
Bobby!
So, quick question around, how this is different from what's available in the AI Scribe platform. Like you're pulling from the EMR as well as the Scribe. Maybe can you expand on?
So for Bobby, we're pulling the information from the AI transcript for the AI scripts like Heidi, for example, and we're making sure that it's agnostic. So if you're able to download it from the AI, or if you want to have a direct connection, most of the information is going to be there. For the disability tax credit form, for example, we want 2 options. Either you're going to fill it out yourself based on the data that's in the EMR, if you would like to, or if the doctor and the patient are in the same room, they're able to discuss the same case, and Bobby's able to translate that into auto-filled data that the doctor is able to review, and once they're ready, they're able to submit.
If I can add to that, after a doctor visit encounter, all of the scribe will have the information, so this can be done after the encounter.
Any other questions? Once. Oh, 8 million hours of physician work per year.
All right, speed up.
Nice job.
Before that.
Bobby can probably help with that too.
CDocs is a patient AI intake platform. Patients give their reason for an appointment to a family doctor. Claude asks smart follow-up questions, and then we use family history and patient history to determine the urgency of their appointment and book them in with the doctor. So as seen, James here, 34, male. He books an appointment, and knowing his family history and the urgency of his appointment and what's going on, we generate follow-up questions, as seen here. Knowing these questions, we can then describe when he's needed to book in based on him and other appointments in the schedule. We can see here, he rates his knee pain on a scale of 6. And analyzing his assessment based on himself, his pain, and his family history of Alzheimer's, we can then get an assessment for him. So as seen in the video, we get a medium priority assessment, which is not as important since he's healthy, he keeps a good lifestyle, but it's also noted to keep rest, he gets different insights on what to do until the appointment arrives, and we can get clinical reasoning of what tests he needs to run in time. He can then request an appointment with the doctor at a specific time.
So that's where the physician part of things come into play. Right now, as you can see, he's medium priority. So he's given an option on the family doctor's free available time slots. Now we go back to the physician and what the physician sees from the doctor, from the patient's point of view. So as we log in, and we're in, the doctor sees any requests for the patient. For example, here James is requesting a follow-up on his knee pain. And as he's generally healthy, the doctor can decide whether to schedule it or not. You can also see additional appointments the doctor has scheduled in his calendar. He also has a track of all the patients that he's treating currently, as it's a family doctor. There you can see, this right here is important because you get to see how a patient's health, like hemoglobin level for one Margaret Chen, and let's say James, the person we were talking about, BMI, fluctuates as time goes on. This is important to make sure that the patient is getting the health care that they need, and for legal purposes as well, we can prove that he's getting better. Finally, we have AI inbox. So what ends up happening is someone who's important, for example, as we saw earlier, Ms. Chen, whose health was dropping consistently, whereas James, who actually requested for an appointment, is still up for medium priority. What would end up happening is James would get an appointment, but Chen would not. That's why we have safety guards in place, where AI automatically detects when a patient is more in need of appointment, even if they haven't scheduled one. And the doctor is then advised on reaching out to the same patient and scheduling an appointment, even if they have not requested one from their side. There we go. Even though Margaret Chen has not requested one, she's in critical condition, and therefore the doctor is advised to have an appointment for her as soon as possible. Whereas James, even though he requested one, does not qualify for the same level of urgency. This way, family doctors save a lot of time and treat the most optimum patient in the least amount of time. Yes, thank you.
Any
questions?
Have you considered ways to mitigate like fairness and privacy issues when using LLMs to generate recommendations for a patient?
That's definitely our next step because patient privacy and security is probably the most important. So it would definitely be a model that doesn't train off our data, and also with making sure that everyone does get care. We don't want to push away someone with a small problem forever, indefinitely. So we would have loopbacks to check and make sure they haven't been waiting for a long time.
Apart from wait times, what about fairness and bias? Because that's an inherent issue when using LLMs in healthcare.
Could you expand on that?
Like for example, if
an LLM for, like we talk about academia, you prompt an LLM for study tips as a female engineer versus a male engineer, you get a different answer. So in healthcare, it does exist as well, because real life data is used for LLMs, and that real life data includes privacy issues, fairness issues, and bias. So how would you mitigate that?
So although we haven't directly acted on the bias, the privacy issue aside, because obviously this data is going to be encrypted at a later stage, we just didn't have the time for it. But the bias issue is obviously valid, and that's why all of our recommendations are just that, recommendations. The doctor sees every recommendation, the doctor checks every recommendation, the doctor makes sure that the appointment it's being said, and the recommendations that's been going through are given the stamp of the hospital. So it's not just the AI that's deciding, but the hospital that's standing behind the AI. And I can see where you're coming from, because if the model has been trained on a, say, predominantly male illnesses, the other genders would get wrong insights. So that's our way of mitigating that. Thank you.
All right, that concludes the clinical workflow excellence. Now our next category is responsible AI, and I want to make sure everybody's in the room. Fast triage, where are you? Awesome. Twice. Yeah, you did. And then intake also got twice. And then AI clinical pharmacist. You're here. All right. I guess a question for Telus and Elspark. Would you like the two finalists to share the presentation again? Back up here?
At least come up here.
All right. Okay, so first one, fast triage, come back up.
You give your shorter version.
Okay. Well, good evening again. This is interesting, unexpected. But,
you guys.
So, the problem is the same, the presentation's the same.
How's yours responsible?
How is it responsible?
Yeah.
I guess that's a good place to start. It's responsible because one, it's working off the data in the EMR, and we are trying that the data doesn't leave the system other than the AI queries, which long-term enterprise AI model, like an enterprise deployment, can be set up. So that way we're being responsible that only data needed, only relevant to your emails and existing EMR. We're not taking it out beyond going to the AI model. And that too, a local model could be set up. The confidence level is, I guess, the biggest next structure that we have, where it will give you a confidence level and it will improve based on the data you give it. The doctor has full control to add to it more details. So as we discussed earlier, so if a practice has rules that these things need to be there, I just got my fracture triage, so at that time, they had the rules, hey, you need to get these x-rays, you need to get this done. And one time, believe me, the x-rays, by the time I got the referral for the x-ray, it was closed. That's what actually triggered me to think about this. So the AI use is where the urgency is required. We are not looking to replace the medical opinion anywhere, rather that's why whatever is suggested, everything here is, as you can see here, is clearly editable by the doctor. Long term, maybe 2 to 5 years down the line, AI models are good enough and they have enough data to be able to start making decisions. But at this point in time, keeping that AI does make mistakes, the confidence level and everything is being kept strictly in terms of how the doctor wants to use it. And frankly, this is something I didn't point out in my initial presentation. They can still see their old inbox. That's why there's a switch. They can still, because I come from a change management background, and change is a big step, and it also is a process in itself. And that's where the responsibility comes in, so that if you're used to your 150 emails through scrolling down quickly, you have that workflow. Adapting to a new workflow will take time. So that's why we're giving that switch. And that's why I wanted inside an existing system where you have essentially a box that opens up. That's my approach to responsibility. Thank you.
Can you explain what information you're sending downstream to the models? Like, so is it the entire content of the email, or is it just the subject? Or?
It's the entire content of the email, and something I don't show here, something I'm dabbling with is maybe having a unique identifier so that we can anonymize it before sending. And when it comes back, it comes that unique identifier. So if we can anonymize some of the details, but pulling out the evidence represents an issue. So probably it's something I'm debating with how that can be done, because pulling the evidence becomes, having that audit trail becomes a challenge if we anonymize the entire stack.
Understood. No, thanks.
Thank you.
Do you think an EMR will block API access to this data because of, privacy?
I'm hoping to work with them so that we can work around it. That's why I said I wanted to be integrated with them. I'm hoping to be working with an EMR so that it can be integrated and we can figure out, see, I'm not the best at regulations of what control the healthcare sector, but I'm willing to work on that. And at some point we have to integrate AI, so a local AI model deployment on your GPUs maybe, can a dedicated for Ottawa Hospital Group could work, probably take care of the privacy issues.
Yes, sorry.
Thank you.
Hello, everybody, again. So, for our second presentation of the day, we just wanted to take everybody through some of the future plans that we had and ideas that came up and we felt fit really well would fit very well into this app. So the first would be appointment scheduling. Very, very important to have that as integrated as possible. So although none of this exists, I'll just show you sort of the way that I would see that working out. So if we were to click into one of the threads here, somewhere in this interface, it may be on the left side under this the patient's name and the type of thread it is, the option to create a new appointment, and then be taken to a general scheduling form, and then it would appear in a calendar option in our sidebar. The next feature that we wanted to build out would be forms to be filled out by the patient before their visit. So simple questions to get out of the way, have the doctor, physician have a little bit of the story before meeting, would reduce the time the appointment would take, saving time and money. So this would introduce a form builder, first of all, that physicians could create these forms in if there were any specific questions. and then save these as templates to easily reuse based on the use case of what the appointment will be about, and it'll lead down to the next.
So another idea we had that we wanted to implement is a pen-it-in style workflow builder. So as you can see, there are a lot of routine tasks the doctor has to do. If he wants to automate these tasks, he can set up an automation, basic drag and drop functionality where he can configure each node to whatever he wants, and then that will set up a routine task, run in the cloud, as long as the flow is turned on. The second thing is a security aspect.
Sorry, I can't hear you.
Go to the mic.
Yeah. So the first point was a end-to-end style builder. So for automations, we want to have it so there are a lot of nodes you can drag and drop, and those drag and drop nodes can be configured as you want with your credentials, and then they will run in the cloud as long as it's turned on. The second point we have was from a security standpoint that you're giving these data to an LLM. So that LLM can be used to train on the patient's data. The response we have is we're going to have a PII redaction layer. So before any request goes to an LLM, it redacts any personal information, and it just gives the LLM only the data it needs. And then when the LLM outputs that data, it rehydrates with the personal identification number or personal information so the clinician can see the actual patient data. So the AI never ever sees the personal data. Thank you.
I just had a question. How do you ensure patient confidentiality? Like, what if the patient emailed you something that's personal and private? How do you assume that the AI model you're using isn't gonna maybe take some of that information?
So to the last point and feature that Lead walked through, I'll just expand on it a little more, what that would look like in practice. So the redaction and rehydration layer that we talked about. So, what that would actually look like is before the request, the thread, email, message, however it's intook, would be stripped of all of the PII flagged in it, all sorts of models, libraries to detect that, and it would be substituted out for like a patient name 1 or something to that effect, brackets, and along with instructions for how the model should process that, it will return the response with that redacted information, and then our own layer would rehydrate it with the correct values. Yeah, never leaving, no PII hitting the provider. So
thank you.
All right, AI clinical pharmacists.
Hi everybody, we are honored to be here. While my partner is setting up the I'm Darius Lazarus. This is my partner Megan Boudreau. I'm a clinician, a physician. Every day in our clinics we make thousands of prescribing decisions, most often without the pharmacist in the room. A patient on 7 chronic medication gets a new diagnosis. Obviously we have to add a new drug. So we do our best, but somewhere in that list there is an interaction we didn't catch. Not because we are not thorough, but because no human brain can hold 40,000 drug-drug interactions adjusted in real time for the renal function, for the hepatic clearance, and for creatinine that just came in the labs today. This is not a failure of competence, that's a failure of infrastructure. And here we come with our solution to this.
So we just made a little tool here, which there's kind of 2 parts to it. One that the clinician would use probably before they see the patient. You can input a medication list here. We made sure that we can take it in pretty much any format. This is the format that we're looking at for this one here, so I would just paste that in. And then if you wanted to optionally add some patient context, you might have something that looks like this handwritten note. This is Darius's lovely handwriting, and it's also in French, so I definitely can't read it. I cannot read it, yeah. And so, oh no, seriously. All right, I'm gonna do some test output.
Oh, okay, so it got...
No. Live demos always fail me. So anyway, basically like what it would do is it goes through the medical list and it will shorten it so that it's in a visually, in a better visual format to be able to like synthesize while you're in your appointment, and then some inferred diagnoses from that, and then also like if there's any clinical flags here. I have a feeling that this is a token thing because this is actually live analyzing, so I'll see if this works. But basically, because this is just a tool, and we know that the experts here are the doctors, not AI. AI does its best, but you're going to have the intuition of whether or not like this looks correct. So you might have to prompt it and say like, oh, like why did you think? Yeah, exactly. Okay, hold on. Let me see if my server needs to.
While we add more tokens
yeah,
to our system, let me tell you a few important points. So first is bilingual input. So I can type in French some diagnosis, or I can just give a copy print screen of my screen and it will analyze it. The medication, you can just take a picture of the medication. For the medications, you can just take a picture of the medication and put it in, or you can type it, or you can dictate it, so it's multiple inputs. And the output, it will give you like a clean list of medication. It will analyze for medication, drug interactions, and it will analyze for prescription cascades. Sometimes a patient comes with a problem, you give a drug that has a side effect, then you have to treat the side effect, and you give another medication, and then the new medication causes another condition. So it's a chain of reactions. And the other thing that it's incorporated in our system, a clean past medical history inferred from all the input that the system has. And if you want to add another drug to the list, it will go through the interaction checker again. And it will also give you some clues on drug adjustments and also exceptional codes that you can apply on the medication, so you have it compensated by the insurance company. It's a little bit different Quebec side versus Ottawa side. We are working with both.
Well, I think we might be back in action.
And we are back in action with our...
Sorry. It's not going to actually analyze it, and that takes like a minute.
Yeah.
All right.
So medication errors are the third leading cause of preventable harm in healthcare. And studies consistently show that 30 to 70% of patients on polypharmacy have at least one clinical significant drug-related problem. And most of those problems are never detected because the resources that will catch them, a clinical pharmacist, is not available with us in the room. But we do have now a solution for this.
Sorry, just to add to the demo, because now that it's actually working, if you wanted to add a medication during the actual visit, this is kind of what it would look like. So basically, then check the interactions with the existing medication list and summarize if there's any contraindications there. Also, this is a Quebec thing, but...
So it already recognized the exceptional medication code for that drug that we put. And it also tells us that there could be some potential interactions with whatever the patient already has, or with one of the diagnoses that patient already has. And this is something that is usable today. You can have it in your office right now.
Sorry.
Yeah. Thank you very much. How much time do you think it adds to the physician workflow?
Ads?
Yeah.
I'll ask the physician.
I think it saves from my work. Definitely, it decreases my cognitive load on a case. Like I can just run the medication list to the system, and will quickly give me interactions that I have to address with the patient. It does more than what it shows here. So it will tell you when was last time that the drug was filled by the patient. So for example, maybe the patient has an active prescription in their file that they haven't filled in for the past 200 days, then I know that that's not an active medication, and I can ask the patient, are you actually taking that drug or not? I can discontinue it. Just to copy paste the medication list from DSQ, EMR, or from the other system that Ontario has, without patient identifying data, it's just like a copy paste, no Control C, and you just paste it here, and then you just let it analyze while I'll do something else with the patient. And at the end, I see, okay, is there something that I need? And we have copy buttons, and I can just put them in the EMR or wherever I need them.
All right. Thank you.
Not even saying this like.
He's gonna comment, trust me. Swear for it. He's probably fine.
All right. So what? Okay, so while the judges are still judging a few of the awards, we do have some initial ones that we're ready to share. Hopefully you're in the room. That way we can give you a beautiful 3D printed trophy. All right, so for the first award is for the social media award. And I don't think this person is here, but the winner is MD. Tessa. So you got some virality here. All right. So the next one is the People's Choice Award. So you all presented, or you were all able to vote on oatmeal. Whoever this winner is, please come up and do like a 30-minute presentation because we really, really want to see how amazing your app is. And the winner is Ad Hoc, 84.
Do you want to take over?
most likely. Because people, all the participants could vote on Unreal, which is people's favorite, and they voted for it. They were voted. Yes. And the version was on Unreal. Basically, people voted. Oh my gosh, you're broken.
You guys? There's like one more to
Half and half.
Alright, so we created ad hoc. Essentially, it's a 4-layered orchestration system, starting with the inbox. We know that inbox management is crucial for doctors, and so we created a way for them to have their inbox tidy, with the demo stuff we have here. We could prepare for the visit, covering the briefs, patient check-ins, the things that the patients would have essentially gone through before their screening, predicted visits agendas where you can kind of confirm that and edit if necessary, and then pre-visit packages as well, where it's like these are the medications and the referrals from the specialists, the notes, the things that would have been hidden originally. You can go in and have like a checklist there, as well as an AI audit trail and a review place where you can see what the AI is actually reviewing, because at the end of the day, if you want to keep the human in the loop, you can approve or reject the things that it says. From there on, you can go to the actual visit side, look at what the visit's going to be about, the covering briefs. Here on the timeline, you can see the actual story of the patient and how they got to where they're at. You can have very specialized notes, action items for the care plans, and then what we like here is the forms as well. Similar to what Bobby had, we also do automated forms as a feature, where you can just kind of fill it in here, automate it, and then again the physicians can go in and see if everything's right, and you kind of check it from there. This is the good stuff, like literally everything filled in by the AI. You can see it for yourself. Everything accurate, you just go ahead and approve it. And everything will be in your audit trail, making sure that it's all correct and reviewed at the end of the day to be approved.
Oh yeah, sure. All right. Gonna smile? Yes.
Yes.
So if you want, make sure you stay, because we're gonna do like a group photo of all of the winners. All right, who's presenting? Clinician. No? Got it. All right.
Okay, drum roll.
Checkley wins the award for most innovative use of AI. And this award has been sponsored by Clinician.
Do you want to join in for a picture? Thank you.
All right, next prize, tally for clinical workflow excellence. Let's do the drum roll again. Winner is Bobby.
I'm going to dedicate this award to Stephen Ballmer.
Did their emails too? Okay. Okay.
All right. Thank you.
First of all, like, awesome work, everyone. Like, to see things like this being developed in a matter of 7 hours by a few people sitting at laptops, like, it's really impressive. So, like, awesome work, guys. So, for responsible AI, the award goes to Intake.
Darren, you want to get in? For the next one. Okay. Now you're good. You got it.
And another photo here. All right. Congratulations to all of our winners. And also, congratulations to all of you who submitted. You know, you put in so much work and I bet so many ideas have been floating around. I really, really hope you continue building. And you know, your work deserves to be out in the world, basically. So thank you so much. Now the winners can all come on the stage. We'll take a group photo. Or actually, or actually, why don't we get everybody up here? Let's do the entire stage.
I'm probably gonna post it like tomorrow. I'm gonna do a post on LinkedIn, but share the pictures for sure. This is just for my personal. But yes, share them.
You don't want to be there?
Okay, maybe some people could be in the front too. You might have.
I just want
All right, everyone, let's take a photo.
Get ready.
Okay, on the count of three, say AGIV. 1, 2.
Wait, we got company. People want to come in.
Oh, what are people? Come on.
We should do a roundup. Like, round up everybody. We should do that.
All right, I think you got everybody. Or if you're not here yet, you better run. Cool. All right. 1, 2, 3. AGIV. All right, a funny one. 1, 2, 3. AGIV.
The team, let's get started.
I leave y'all unattended. That's what it's about. Yeah, that's
Good job, guys. Where's the memories of
Alright, 3, 2, 1. Alright, take cheese. Okay, we'll say thanks to the guys that are doing this. Oh, I'm sorry. My Just one.